Welcome to this e-learning module on multi-drug resistant TB. In this module, we'll be focusing on the DRTB treatment and its interaction with ARVs. This is part of one of the Wits RHI catch-up sessions. Now we need to look at our patients who are already HIV positive and is also presenting with DRTB. And one of the challenges is due to the complicated DRTB regimens, it also complicates our options in terms of ARVs. I'm not going to be covering the ins and outs of the HIV management, but I want to spend a little bit of time on how the different regimens impact on each other. To do this, we want to run through a few specific scenarios. And so let's start off with a patient who's already on ARVs and now presents with DRTB. The most common scenario you would usually see is your patient who's already on a first regimen, tenofovir, emitricitabine, and efavirenz. And in those patients, our first priority is to get them onto the DRTB treatment. And at that time, you will keep them on that regimen, but you will take certain baseline tests, which will include a viral load, hepatitis B, because that's significant if we're going to stop the tenofovir, creatinine to see how those kidneys are doing, and a hemoglobin. When your viral load result comes back and the viral load is lower than detectable, it means we can safely switch the patient off to tenofovir. If you remember, the patient is going to be on kanamycin, which is quite nephrotoxic. Tenofovir is also known for its possible nephrotoxic effects, and therefore it's seen to be not good practice to give two nephrotoxic drugs together over a period of time. And best practice is if the viral load is LDL, you can change your tenofovir to abacavir. If the viral load is detectable and you have an HB that's over 8, we don't initially want to make a straight switch from tenofovir to abacavir, as there's a very high risk that if there's resistance there, you're going to lose that abacavir if the patient's already resistant to his lamivudine and efavirenz. In this scenario, depending on the history, if it's a patient who's been failing repeatedly over a period of time and you're fairly sure there's resistance, you might at this stage decide to go straight to second line. But sometimes it might be a patient where it's the first time the viral load's gone up, and it might even have been affected by them developing DRTB. So in those scenarios, we can do a single switch, but we will use AZT, and we're only going to do that until we have sorted out and figured out what we're going to do with the viral load. The reason why we choose AZT in this scenario is because AZT is a much higher genetic barrier than abacavir and is a little bit tougher in case there is underlying resistance. Certainly patients like that you would want to discuss both the switch as well as the follow-up in terms of making decisions about future regimens as you keep an eye on that viral load. You might also have a scenario where the viral load is detectable but the HB is under 8. And in those scenarios, it is actually possible to keep the tenofovir going and just to monitor the creatinine closely. A similar issue would be if the patient is hepatitis B positive, if the kidneys seem all right, one can potentially use the drugs together, but you will have to have a very close monitoring of the kidneys. Once the patient has had their injectable phase, we will actually go back to the tenofovir as long as the creatinine clearance is still good, and you would probably recheck that the viral load is suppressed at that time. Different scenario might be a patient who is already on second line treatment by the time you start them on their ARVs, in this case second line AZT, 3TC, and lopinavir ritonavir. And in those scenarios, we can continue our second line, and surprisingly enough, the second line regimen has actually got less interactions with DRTB treatment than it does with DSTB treatment because we don't have rifampicin. So in this case, you do not even need to double the dose of the lopinavir ritonavir. So let us look at a second scenario where you have a patient who is not yet on ARVs, HIV positive, been diagnosed with DRTB. And of course, our priority is going to be to start the patient on DRTB treatment, and we will be preparing the patient for ARVs. Important to do your CD4 as part of your baselines, and to remember to do things like your CRAG if that CD4 is under 100. But all of your DRTB patients are considered stage 4 and are indicated for fast tracking on ARVs. And what that means is that it is expected that as soon as you start your DRTB treatment, that you should be starting your ARVs within 7 days. Notice that this is quite different from our normal TB treatment, where we have a recommendation of waiting between 2 weeks and 2 months. It has partly got to do with a high mortality of MDR TB treatment, but the reason why we don't need to wait the whole 14 days like we do for drug-sensitive TB is that these patients are not on rifampicin. So you don't have the same adjustment that needs to happen within the liver and the same risks of hyperbilirubinemia as we see with patients on rifampicin-based regimens. In practice, though, it's sometimes quite challenging to start a patient on ARVs in such a short period of time, considering everything else that needs to happen around the DRTB. The regimen of choice is nabacavir, 3-TC, and efavirenz. As mentioned in the previous case, we do not want to use tenofovir. Abacavir is a good first-line drug. But if the patient, for example, is hepatitis B positive, you could decide to use your tenofovir-based regimens with very close monitoring. Once the injectable has been stopped, you will change the patient to the 1-TFE, tenofovir, imidrocitabine, and efavirenz, proviso that the creatinine clearance is over 50 and that the patient is virally suppressed. But what about patients on bedaquiline? We would hope that life is now simpler because the patient is no longer on a nephrotoxic drug. But unfortunately, there is an interaction between efavirenz and bedaquiline, and the two together is contraindicated. So if you have a patient who is presenting on tenofovir, imidrocitabine, and efavirenz, we need to consider what to change that efavirenz to. To make that decision, we will take a baseline ALT, and if there's no liver disease, we can switch the efavirenz to nevirapine. You can see I've put CD4 there in brackets. That's not something that's particularly mentioned in the training material, but of course there is a concern about using nevirapine or initiating nevirapine in people with high CD4 counts, so in women with a CD4 over 250 and in men with a CD4 over 400. The challenge with our information about the higher CD4 counts is it is specifically for people when they are initiated on nevirapine, and we don't have so much information of people being switched from efavirenz to nevirapine and whether it is as relevant. If there is no liver disease, or if the patient has a high CD4 count and you're feeling nervous about using nevirapine, we need to switch the efavirenz to something else. And the main one that is recommended is raltegravir, which is a drug we do not have easily available in the public sector. Lopinavir ritonavir is an option, but the ritonavir is a little bit of a booster and can boost the bedaquiline and can potentially also therefore potentate that increased QT interval. So if you look at our patients who are already on second line, so zidovudin, 3-TC, lopinavir, ritonavir, we're actually going to keep them on that regimen. But because of this possible potentization of this possible boosting of the bedaquiline, we will need to be doing weekly ECGs to make sure that that QT interval is not prolonged. So what about our DRTB patients who are not yet on ART at the time of initiation? We're obviously going to start our DRTB treatment. Very important to do the CD4 and a baseline ALT. And then there's various regimen options depending on what else is going on for the patient. So if you do have raltegravir, that's by far our first prize. As a matter of fact, these days, probably more dolutegravir that is available through the third line committee. And you can consider lopinavir, ritonavir, but if you do, you would be having to doing regular ECGs. If the patient's got kidney insufficiency, you might use abacavir. If the CD4 count is not too high, you can use nevirapine, or you can use tenofovir, 3-TC, and nevirapine. Again, if the CD4 is under 250 in women and under 400 in men. In summary, remember our major drug interactions between DRTB medicines and ARVs. Efavirenz and bedaquiline are contraindicated. Tenofovir and kanamycin and bedaquiline and lopinavir, ritonavir will need weekly ECGs. If you do need to make a switch in the ARVs, if it is at all possible, make sure that the viral load is fully suppressed for patients who've been on treatment for longer than 3 months. Thank you. Do see our other modules in this section on defining and diagnosing DRTB, on baseline investigations, and on the new DRTB regimens.